giving people opiates in this context, you are not giving them opiates as needed for their pain. You're not giving it to them to make their pain better. You make it clear that these opiates, I'm giving them to you so that you can do the things that we talked about you needing to do in order to get towards your goal, right? So I'm going to give you this opiate so that, I know it really hurts when you walk right now, but you're going to get, you're deconditioned. It's going to get better over time. Take the opiate a half an hour before you go for your walk. That'll make the pain less. You'll be able to do it. Try that, and we'll see how it goes. And if it helps, and if it helps them do the things they need to do, then your opiate's probably helping, right? It's enabling your behaviors. You didn't take it after something bad happened, right? You took it, you took it before, so you're reducing the punishment of doing the things that make things get better, and that can substantially help. Also, I think second best is just taking the opiate out of the learning equation, right? So if you give somebody a long-acting opiate on a time schedule, so you give them an opiate that's just kind of constant level, then there's no behavioral training that comes in play from that opiate, and maybe, just maybe, you're reducing the learning that happens from fluctuations in pain. So that's sort of your second best option in terms of how to use opiates to move towards these functional goals. Okay, so I want to talk a little bit about, because one of the things I see working as a QI person is that generally healthcare systems are set up horribly. They do not support their clinicians in doing what I just told you to do and trying to do pain management the right way. So what can we do to help set up processes so that clinicians have a chance, right? Because even the most aware, well-trained clinician, right, is gonna have trouble focusing on long-term outcomes when they're faced, one, with a highly distressed patient, or they're in a place where they're not feeling so good, right? So if you as a clinic, you're tired, you're really overtired, you're stressed out, that's gonna overactivate your reward learning circuits. You're gonna become short-term focused. What can we do in order to help support clinicians at the times when, where their reward circuits are not gonna be their best friends? So we need to figure out ways of enabling clinicians to be empathically connect with their patients without risking this impulsive relief-focused decision-making. And I think of this is cleaning our house before we start our diet, right? That's not the way to do it, but nevertheless. So what do we need to do system-wide to support clinicians? Well, first off, we need our clinicians well and well-rested, because we know stress amplifies reward circuit drive. It generally increases short-term focus. So the more stressed you are, the worse, the more driven you will be towards short-term relief-seeking behaviors. So I know this is easier said than done, but making sure clinicians actually have time for their patient visits, that they're not backlogged and trying to run from one clinic to another to get patients, not scheduling them for like 18-hour shifts so they're exhausted at the end. Things like that are actually very, very important to get behaviors back in control. Some of the things that I think are a little more system creative that I've seen that have worked really, really well for some people. One is using team-based care, or even multiple providers in the same visit can be incredibly helpful for supporting this, because what you find is if you have two clinicians in the room or two clinicians making the decision, one can catch the other, right? And this isn't a you just don't know enough or you're not experienced enough kind of intervention. I've seen like some of the most skilled, experienced like addiction and pain providers do this because it's the only way they can stop themselves from reacting to their own drive, right? So if you have somebody else there who can catch when the other person's just getting a little too involved in the patient, just can't handle the distress and is like, okay, no, we're just going to do this job. And then you can have your other clinician step in and say, no, I think we need to stay back, come back, let's go back to the focus on the goal. I don't think that's helping. You can basically like piggyback off each other to help with care. And I know there's a lot of, it's not usually focused on this, but there's a lot of movement towards doing team-based primary care, adding mental health treatment into primary care settings and things like that. I would just say, if you know you're going into a situation where it's going to be hard and uncomfortable to work with your patient, the patient's going to be really distressed, that might be a time when, bringing in the psychologist or the social worker into the visit with you, or having the nurse there is worth the extra time on their part, because it can stop you from heading down paths that are going to cause you problems in the long term. Similarly, I've seen places do really, really well by adding a specialist consultation service. The idea is you have ideally a pain and addiction specialist, and I've seen this done in a few cases, but just a pain or just an addiction specialist would be great. I've even seen clinical pharmacists do a great job in this role. But the idea here is you have somebody to consult when you hit a point where you're not quite sure what the best thing to do is, or you think things are going bad. And I know this is framed as you're seeking help with the knowledge, like you don't know what to do, but I will say this works just as well when you hit that point where you think maybe you're just not helping the patient anymore, right? That whatever interactions you've set up are not going in a good direction. Getting somebody on the outside with information about what's going on, but not that emotional connection that may have gotten built up, can help with decision making, help change the pattern of decisions, think long-term in ways that can be really, really difficult if you have a long-standing, built-up relationship with a patient that's just not working, essentially. And there's whole models, there's places that have set up what they call opiate renewal clinics, and they've done a whole bunch of work on those, where essentially you just take the patients that you're having trouble with, you send them off to a team of providers who sit there, work, come up with functional goals, reset, maybe taper their medication, change their pain management plan, and then ship them back to the primary care provider with a, look, here, we did a reset, let's see if we can go back from there. And that can be a very, very effective way of improving outcomes. And there's lots of clinical evidence for that. These clinics have been well tested. Other things that can help, and I know these generally don't feel good on the clinician side, but checks on opiate prescribing decisions, anything that slows down the opiate prescribing process is going to prevent impulsive decision making and encourage reconsideration. Like, okay, yes, this person is desperate in front of me, but I'm going to have to go through a ton of paperwork and a bunch of order entry checks that keep telling me that this is a bad idea before I actually can prescribe the opiate. It gives you time to change your mind, essentially, if that's in sort of disconnect from the emotional connection that you may be having long enough to think about whether what you're deciding to prescribe is a good idea. And so things just like simple order entry check processes, urine drug screening, for example, is another great way to slow things down. You got to order a lab test, so on and so forth. Checking your prescription drug monitoring program. It provides useful information that will help guide your decision making, but even before you get the results back, it also just slowed you down, and you can't be impulsive when you've got that giant gap in the middle. So anyway, don't get quite as annoyed at your healthcare systems when they make it really, really hard for you to prescribe, because to some extent they're trying to help you. Okay, so simple take-homes. One, chronic pain we know can shape development of habits that encourage relief-seeking and pain avoidance. Analgesics can reinforce the development of those relief-seeking behaviors. They can also shape the behavior of clinicians and loved ones that'll really encourage opiate use and immediate relief-seeking behaviors. And so what we really need to do is change the way we think about pain, change our focus in pain management on getting people towards their quality of life goals, getting them doing the things that they care about that are meaningful for them, rather than really thinking about how much pain they're in right this second. Coach people instead of saving people. Okay, so does anybody have any questions? I'm going to go into another general topic, which I think this is where things tend to get hairy and where we start to run into things that look like addiction and need to be treated like addiction. Because quite frankly, the effective treatments for pain and addiction aren't really that different. So because the circuits that underlie them are very similar in a lot of cases. Yeah.
A quick comment on the section where you talked about physician wellness and rest and all.
Yeah.
I spent many years working at Kaiser as part of an employee and physician wellness program,
Mm-hmm.
which eventually got sufficient funding and developed good programs. And one of them included offering physicians a 4-hour meditation retreat on a Saturday that was free and included lunch. It was open to 25 or 30 people.
Mm-hmm.
And it never got more than 12 or 14, and it was always at less than 50% full and therefore open to other health workers. So the sense of providers not being able to or not being trained even to think that they could take advantage of something being offered by their own employer. So that is, to me, says this whole issue of self-care for providers goes way back to other issues in their training or whatever
Yeah.
else. So I just wanted to share that. Even when that's offered, it was rejected by the very people who needed it.
Yeah.
Just piggyback on what she said.
Absolutely.
The hospital that I work at, I implemented a meditation program where
Mm-hmm.
I had a woman come in who's an experienced meditator,
Mm-hmm.
train the whole staff, because we're always talking about mindfulness,
Mm-hmm.
evidence-based, and nobody showed up. Some of my colleagues showed up that just for support for me.
Yeah.
But I remember my boss, the director, said, I got to have my hair done, and it was like a 4-month series.
Uh-huh.
We work with people after they develop addictions to get them off
Mm-hmm.
the pain meds. So
Yeah.
she's so right. There's something deeper than that has to be fixed. Like people don't embrace their own self-help. They're
Yeah.
healers that offer it to
Just-
patients.
Yeah, those are really good points. So the point that was just made for the people who couldn't hear it is that clinicians often don't take opportunities for self-help and may have learned not to, basically through training over time, and that really kind of helping clinicians embrace the idea of wellness and taking care of oneself is probably an important intermediate step to getting them to train others in doing that. And obviously, patients model what they see from the people that they see as helpers. And if clinicians don't think it's important to take care of themselves, then patients probably won't either. I think it's an excellent point. Yes.
For your recommendation
Mhm.
concerning what happens if people improve functionally
Mhm.
over a period of time, but the pain persists?
Mhm.
And so are you recommending chronic opioid prescription, even though the person has reached their functional goals?
Mhm. Yeah, so the question is, okay, let's say if you have a person who improves functionally on opiates, is doing well, but they still have substantial pain, do you keep them on the opiates? And the thing that I would do in that situation is keep monitoring their functioning and quality of life, and basically check for risks, right? So one thing you find is as people get older, they start taking additional medications that could increase the risk profile of taking opiates, and we'll talk a bit more about that. That might encourage you to taper it. But so long as the patient is highly functioning and seems to be doing better on the opiates than when they're not on them, there's not any real reason you need to take them off. I would just say in a lot of cases, patients will start to decline later over time. It might help in the short term and might start getting worse later. At that point, you want to take them off. But there's no set limit on how long somebody can take an opiate if it's working well for them. So you really just need to focus on is it helping? If it's helping, then let it go. It's just most of the time, it's either not helping or the risk compounds as people start taking more and more meds, or start getting more frail. They might get additional sedation and things like that, or confusion, and those are conditions where you need to take people off as well. Okay, so I mentioned, but didn't quite explain. So one of the core symptoms of addiction is use despite negative consequences. And another way to say this is, if you read the basic science literature, is the idea that relief seeking or drug seeking becomes compulsive and insensitive to punishment. It gets to a point where it doesn't matter how bad things are getting, all the negative consequences that one might be experiencing by what they're doing, it doesn't matter. That will no longer shape behavior, and you just get stuck in this cycle of compulsive relief seeking. So this piece, this idea of compulsive reward seeking that's insensitive to punishment, there's actually been a good amount of research, and we understand what causes that. And I'm going to walk you through where that comes from, because it has some implications for how we treat patients and who we think is most likely to be vulnerable to developing chronic pain and addiction problems, and what sorts of things we can do to help bring back this punishment sensitivity, essentially, so that they have more ability to change their behaviors and head into recovery. So I mentioned we've got the dopamine neurons, right? We've got dopamine neurons that send input about reward opportunities to your nucleus accumbens. And those nucleus accumbens, in the nucleus accumbens, there's a set of neurons that are called medium spiny neurons. And they basically are the ones that make the decision about whether or not you're going to take that opportunity. Are you going to do the habit that you have the opportunity to do? And there's two main types of medium spiny neurons. One acts basically as the accelerator on these decisions. This one says, yeah, go, go, go on your habits. And there's another set that act as the brakes. They're the ones that stall the decisions, say, no, 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 not yet, not yet, not yet. And the two of them together combined to essentially make the decision about whether to do them. The other piece I would point out is that without the brakes on this system, it's a really simple circuit, right? Like I just told you, I can explain the whole thing in 3 neurons, right? Like that is incredibly simple from a neurobiology perspective. This is really quick, fast, simple decision making. Without the brakes, it outpaces all of your fancy cortical processing, right? Like cortex is great, it can do all sorts of complex things, but it's slow. It's got a lot of processing to do to get there. If you don't have brakes on this system, your cortex can't keep up. It's going to be too fast, right? So one of the things that matters in this decision making is whether or not you have enough brakes on the system to allow the rest of your brain to have some input into what you're going to choose to do. Because without that stalling part, you wind up really driven by the choices that those reward circuits make, those habit behaviors. So